So as we get started, I want to ask each of our panelists, as they look to do something in specialty VBC, how did they choose their actual care model, like their nuanced care model? Because ultimately they were thinking it's going to create value for somebody. So let's just start there.
Yeah. Hi, everybody. I'm Beth Houck. I'm from SonarMD. I'm a little scared by some of the more recent comments about doing one-off things, because that's kind of what we do. We manage patients with inflammatory bowel disease. So we're founded by a GI physician who had the recognition that a lot of his patients, who he'd given them their his cell phone number and told them, like, I've been your patient forever, please call me if anything's wrong. He had the revelation that they're not doing that. He got his hands on some data. He learned that in the 60 days prior to an inpatient setting, ER or inpatient admission, patient wasn't even going to the practice. So he's like, why aren't they calling me? So he had the recognition that these patients were deteriorating without warning. Like so many of what you guys do, people are deteriorating without warning. There's data that helps tell us that, but that happens. So he was kind of in a unique role with the AGA, and so he also recognized that GI's revenues were declining, and so he decided that he needed to be able to find a way to bring value-based care to the GI practices. And did some more analysis where we learned that inflammatory bowel disease accounts for half of the variable spend within the chronic GI space. So with that became the launch of SonarMD. I was telling somebody the background of the name. He was watching The Hunt for Red October, and he was like, we need a ping system. So we need a system that manages patients, or kind of is a radar between visits, so that we can get people to care sooner. That was a long answer.
No, that's perfect. So Mike, on the behavioral health side, there's so much that we can do for patients. How did you decide you wanted to kind of tackle more serious mental health? And what did you do in terms of developing that care model to actually be able to help these patients?
Yeah. So I'll give you a little bit of background. So Michael Lipp, Chief Medical Officer of NeuroFlow. NeuroFlow, Cappy was on the last panel, takes a population health approach to behavioral health to improve outcomes. And NeuroFlow recently acquired Quartet Health, where he built a full risk program for patients with serious mental illness, focusing on their behavioral, physical health, and social needs in a full risk way. And by background, I'm in primary care and specialty care, so I'm boarded in internal medicine and gastroenterology, oddly enough. And I spent most of my career in value-based organizations like ChenMed, DaVita Healthcare Partners, where I worked with Reza, Arbital Health, and I was at CMS at the Innovation Center working on primary care and specialty models like ACO REACH and kidney care choices models. So brought some of that experience to the whole health program where we focus on serious mental illness. And part of how we ended up with that model is, I'd say first, just what I saw clinically. And just in a lot of the primary care models, there was always a population that didn't quite fit. And they didn't like coming to the office. The PCPs didn't know what to do with that population. They didn't have the expertise to manage them. And a lot of the primary care models, and there's a lot of research on this, that the patients with serious mental illness didn't have the same outcomes as other patients. And so when we actually looked at the data, these patients were costlier, they had higher MLRs, they had a fragmented care. So a lot of times they'd see, even if they saw a behavioral health provider, but a lot of times they wouldn't even see anybody. Well, a third to half of the patients with SMI actually didn't see any behavioral health provider in a year. Their care was very fragmented. And so we married that with just what the evidence says around the care that can be provided, what the evidence says patients can and should be getting, things like injectables, access to care, preventative visits. That just wasn't happening, and that was part of the genesis for that model.
All right, Rob, tell me, there's like a lot of solutions in that MSK space, from early triage to various PT-related entities versus working with the orthos. So like, how did you decide if you want to drive value in MSK? What's the sublane that you chose, and how?
Well, if you're going to take risk on total MSK spend, which is what we do, we subcap the total MSK spend, you have to do all of that. So that's kind of the bad news. Where we started was really in the surgical avoidance area, because that is where the tremendous opportunity is, the inappropriate surgical avoidance. And 2/3 of spinal fusions are unnecessary, 1/3 of total knee replacements are unnecessary. And so we've got to get to that. And we were founded by a couple of spine surgeons who found themselves doing an increasing number of revisions on patients that they recognized never should have had surgery in the first place. And that's really what led to the founding of Livara. And they pioneered a method of strengthening and PT that for a large number of patients could avoid that surgery from lower back pain or any number of other issues. And treating multiple issues that had traditionally been believed to require surgery, severe spinal stenosis, and they found that they could actually avoid surgery and have really good outcomes. So that's where we started. And then as you expand the risk you're taking, you obviously recognize that, well, there are a whole host of issues, though. For example, some patients are surgical candidates, whether it's a chronic condition that can be treated through surgery, but there's still opportunity to optimize that surgery, either by making it less invasive if you have multiple options, or by just optimizing the surgery through appropriate post-acute utilization, things like that. And then, of course, there are the urgent or emergent cases, fractures, et cetera, and similarly, still the opportunity to optimize the outcomes of those surgeries. And so you have to really expand it by doing all of it. And so it starts with the triage to make sure that you get patients to the right place. If they need to see an orthopedic surgeon, then they need to see an orthopedic surgeon. But if they don't, then the key is, to try and route them in the appropriate direction and have that program for the conservative care treatment, if you will. And then for the patients that do need to see a surgeon, then engagement with the specialists, navigation to the appropriate specialists to optimize that. So it's really the full journey. And if you only do part of it, you can achieve some things, but you can't take risk on MSK. It's just not possible.
So I guess, Rob, let me follow up on that. Whether it's MSK or others, right? Everybody's trying to decide if they want to build a small digital solution that's layered on top versus working with the docs. They come in at different price points, different risk levels, and different abilities to scale. So in your space, how do you how do you discuss this with the folks that prefer to have a very thin digital solution that gets layered on top, as opposed to doing something much more meaningful, deeper level of risk that includes the docs?
Sure. If you look at the market, Hinge, Sword have built very successful businesses delivering a small digital, they wouldn't call it small, but it's a digital solution for PT selling to employers. And they have built great businesses. I don't think with that solution alone, they might put their fees at risk, but I don't think with that solution alone, they would actually take true upside-downside risk on spend. And so if that's where they want to be, then they want to be. There are other, in the payer market, there are utilization management folks who are looking to go upstream a little bit, who are looking for digital solutions that maybe are a little bit more clinically oriented, though, and do have some services component from the clinical side. And so you kind of meet them where they are. And then there are others that are really saying, no, the only way to get at this is to partner with someone who's willing to take the risk and who will engage with the specialist. So we actually are sort of have components where we can meet people where they are. We do not play in the employer market. We are not trying to compete with Hinge or Sword. But to the extent that a payer says they don't need all of it, then we won't take risk, but we may still participate with them in delivering value to patients. But that's really the key. And MSK is so unique because nephrology, oncology, cardiology, these specialists have longitudinal relationships with patients. They're managing a chronic condition. Our specialists are surgeons. So we talk about attribution. I'm not worried about attribution because, again, there's no longitudinal relationship. This is about when we are engaged with specialists, how do we put the right incentives in place on an episodic basis to optimize that encounter And then generally, if they don't need to be there, keep them away from it. But so it's a different animal that requires a different dynamic and a different set of incentives.
You talked about the payer. When it comes to the GI space, how do you think about the different payer segments and how it impacts your value creation? And then eventually we'll get into the contracting.
So people with inflammatory bowel disease are generally diagnosed in their 20s. So we take care of a commercial population. A lot of the plans that we primarily are taking care of a commercial population for ask us to also take on their MA patients. They behave somewhat similarly, and the actuarial kind of profile of the patients tends to be similar, so we don't get ourselves into trouble by taking care of the both populations in basically the same way. So that's the one really practical side of it. I think of the part of your question is also when we go to talk to payers, when we try to sell to payers, GI is not high on their list. They've kind of gone through each of the different service lines. And then when they get to the GI service line, this is a little bit kind of a corollary to the other question. When they get to the GI service line, they want it fixed. They want the whole service line. And they don't want to just hear what I have to say about a really high cost, 1.5% of your population, 3% of your spend. They don't want to necessarily just hear about that. They want to make sure they're solving, hey, we have a GI shortage, people can't get in to see their doctor, we have people with stomach aches who are waiting months and months, and then having a lot of churn and utilization because of it. So they want to solve all of it. So that's probably my biggest challenge, is either convincing them, let's solve all of it, but let's start with IBD, or partnering with somebody else, because I'm a small company right now, partnering with somebody else so that I can solve their entire problem.
So if I can add, from the different payers, so there's a lot of differences. So I put this in 3 buckets. So one, the contracting process is very different. So if you go through CMS, if you have a commercial payer, it'll be a different contracting process. The value levers are different. The prices can be different. So doing the exact same thing for a commercial patient with commercial insurance versus a patient that has Medicare, it could be 2 to 3x different, the exact same avoided hospitalization or surgery. So the tools, I think that was mentioned on the last panel, things like utilization management networks, you're going to have different tools at your disposal with a private payer versus Medicare patient. The last one is the population. I think you referenced this. The populations look different. So a Medicaid population is obviously younger. The way comorbidities, the disease burden looks different, as opposed to an older population that may have more comorbidities across. You'll have more on the tails in the Medicaid population. And also there's a lot more churn. So if you're investing in a value-based care model where you're investing in the patient, the team, that patient might not be your patient in 2 years. And so all those kind of factor in the exact same care model, how you would adapt it to different payers.
So let's now pivot a little bit on value creation and contracting, right? So anything from, you mentioned, Rob, there are companies that put their fees at risk, for having some pre-qualified, predetermined measures, all the way to people who have some level of pay for performance, do full risk on these things. So help me understand, when you decided to go down this route, where did you start and where are you now?
Well, we started just delivering services for a case rate. We had a more limited set of services. We were confident in our outcomes. We could have some value attached to the case rate as well, some pay for performance aspects to the case rate, but it was a case rate. And what we realized is that we couldn't truly deliver the care to the patients that we wanted to deliver under a case rate arrangement, generally speaking, because obviously we're limited. There are financial constraints. You can't spend more than you're earning in your case rate. Whereas the incentives, obviously, and when you have full upside downside risk, are clear. As long as there's an ROI to the next dollar you spend, then you should spend it. And so that allows us to really deploy everything we need to deploy. We employ surgeons and PM&R docs that we deliver consultations to patients virtually. what we have found is that patients will not, if you're trying to educate a patient on the risks of surgery, on the reasons not to have surgery, there's no one that can deliver that other than a surgeon. And so we provide that to patients, and those are the types of things that are very difficult to provide under a case rate. And so that is really what allowed us or really led us to expand. As well, of course, as we saw the appetite growing in the market. If the appetite's not there, then you can't offer it. But we saw the momentum among risk-bearing primary care groups, among payers, to really sort of offload their MSK spend or risk or a portion of the risk and look for someone to kind of take that on. And we felt confident because of the outcomes we had under the case rate that we could easily transition to that.
How long does it take to get that confidence, right? People who want more risk want to have some level of confidence that their care model can drive a delta in one or two behaviors, whether it's site of service, the type of device that's being used in hips, or not having surgery at all, I suppose, right? Like, how long did that take, and what type of additional analysis did you need to do compared to some counterfactual to say, okay, now we're ready to go at risk?
We're a little unique because we've been doing it for 17 years.
Okay.
Again, a case rate for a large portion of that, but even while we were delivering these case rate services to Scripps and Sharp and Providence and some of these leading organizations, we were doing the longitudinal claims-based studies independently validated on 50,000 MA lives for over a 3-year period. And so even though we weren't compensated necessarily fully for what we were saving, we could see what we were saving. And so, I've been here a year and a half. I was recruited here, and the main thing that attracted me here was I saw a company that needed help understanding how to grow, but had proven this clinical model. And I think one of the risks in launching value-based care businesses is there are some folks that go get the contract and then figure out the care model. That's pretty risky. And so I saw this company that had the care model, and we just needed to operationalize it and scale it.
If I can add so the first thing you do is hire Arbital. So they've been a great partner. I'd say, think of kind of 3 aspects of it. So one is you have the care model of making sure you pick the patients the right way. You're really narrow, and I think can often be a tension, say, with the payer on wanting to really focus in on the patients that you can make an impact, but that number might be small, and having inclusion, exclusion criteria, that might be hard to operationalize. You see only patients that you've engaged. You do a larger cohort of patients that you've not engaged and take on that engagement risk. So one is the patient population. Second is what you're willing to be at risk for. And so do you take Part D? Are you A and B? Are you a bundle, kind of a time-limited risk, or are you doing longitudinal risk for MLR, total cost of care? These are all things that you have to consider. The other one is what you're being compared against, so your benchmark, and how you think about your comparison group and what success looks like. And I think that becomes important when you start these models. Are the goalposts going to move over time as you show value, as you lower total cost of care, lower MLR? Is your benchmark going to move along, or have you kind of set that up front? Those are all things that you need to consider in the contracting process.
The trade-off of the patient selection is never easy, right? If you're doing something fantastic, the other side wants you to take care of a broader patient population, and then your ROI, when it comes to next year's reporting, goes down and down because now you're caring for less expensive patients, although you're doing the amazing thing that they actually need. So how does this impact some of your GI patients, right? Because some of them are super high cost to begin with Rise, and others are not today.
Not today, yeah. It's I was talking to somebody earlier, and they asked me whether or not we take we're directly contract with primary care, and we don't right now. Our attribution model has us taking care of patients that have seen a GI within the past, say, 18 months or so, which means they're automatically a little bit higher cost. But then my number of patients I'm taking care of, just to your point, is a lot lower. And we also know from looking at the data that patients that have inflammatory bowel disease, it's very like this. So if you managed, you're kind of flat. But a patient that is in remission right now, meaning and not on a biologic, they can literally deteriorate overnight. There's something called silent IBD. I mean, so the primary care population should care, but you're right. It's almost like two different models for me. $40,000 total cost of care, $18,000 total cost of care. So completely different population, and I either have to decide like the big N is worth it, or we do two different models, which I'm sure there's like an actuary out here saying, no, don't do that, or a payer that has to do the reconciliation, right? We have to figure that out because it is tricky.
Or at least two-tier pricing, perhaps.
Yes,
right?
yeah.
So Rob, before we turn into the audience for questions, any advice you would give to a new specialty solution that's about to take risk now that you've been doing this for a while? Lessons learned, advice?
Yeah, I think that probably the two trickiest things are how to engage with the specialists, which varies, as I talked about, dramatically based on the specialty, I think. And just the other thing is back to sort of the economic discussion, I think, because that has two levels to it. One is sort of on a broad basis, how much can you spend on a patient versus the savings you're generated. But there's also a more short-term issue, which is most of what we get paid comes way down the line. There's a performance here, there's a delay, there's a settlement. We charge a program fee along the way to fund our operations, but that only funds so much. And so how do you manage your cash? And even though spending X might generate the right savings, I may not be able to spend X from just a cash flow perspective today. And so you've got to really be aware of that balance. And obviously, trying to generate more margin on your program fee may impact the savings you generate down the line. And so, that's you've got to just balance it, and you've got to really. It only comes through experience. I don't know any other way to do it. But segmenting the population is extremely important, right? You just have to invest appropriately to the different patient groups.
Mike, I'm going to ask you a different question. Okay. You have payvider experience, right, as I do. Sometimes they're a more sophisticated buyer. They've already maybe reduced admits per thousand down to 175, 160 more globally, right? How do you make sure that whether it's behavioral health or some other entity that is doing specialty care, like the thing that they're doing is actually incremental to that more sophisticated buyer?
Great question. I think breaking it down to what the actual value levers are, getting really granular, like what is happening now that should be optimized, whether it's, like my dad's 87, he lives in South Florida, and his friends all get screening stress tests. They shouldn't be doing that. Asymptomatic. And so looking at, hey, are patients that are 85 or 90 years old getting screening colonoscopies when their life expectancy is short? And really breaking down what are the things that are happening that it should not be happening, and what's the value creation. So I think understanding that. The other one is really talking to specialty providers and understanding their day-to-day, their business models. And this was hard for me as a specialist going into a value-based care model, that it's directly at odds. When you're particularly a procedural specialist, your revenue is dependent on procedures. And when you move into value-based care, you teach the primary care providers to not call you and only give you the most complex patients. And sometimes that means you don't do a procedure. And that's scary. So I think understanding the perspective of the specialist. And then the last one I'll mention is not to forget what the patient wants. And in these specialty models, that patients often get confused and they're kind of bouncing around the system, and they kind of want to go to one person, one provider to help them make this complex system more simple. And so not to forget the perspective that these different specialty models have on actual patient care.